warm welcome to you all for this CMA. Today's topic is limb salvage in trauma. It's one of the very useful topic to all the budding postgraduates as well as young consultant orthopedic surgeons. So, today's talk, limb salvage in trauma, especially by a renowned plastic surgeon from Jim, Dr. Bully Boydie. Is DNB general surgery and MCH plastic surgeon, and as well as consultant plastic surgeon working in GEMS. So, I welcome Dr. Bully Boydie to present his talk on limb salvage in trauma. Thank you.
Thanks. కూర్చుంటారా? Start. Very good evening to all of you. At the outset, I would like to welcome you all, and I would like to thank the GEMS organization as well as the management for giving me this. It's okay. Okay. Good. Okay, convince for giving me this opportunity. I would also like to thank each and every one of you for having taken your time out from the busy schedules and practices. I hope I'll make your time worthwhile. So, I've seen a lot of postgraduates here. So, my question to postgraduates is, can you please, any one of you tell me what exactly is a mangled extremity? I don't think anybody is listening. Are there any postgraduates here? Yes. Yeah, please. Okay, sir. Can you just tell me what is a mangled extremity? When you call an extremity a mangled one? Mic is there? Please, please. Yes, yes. Yes, yes. Would you want to qualify your answer? Yes, so not always. Yes, I give you that. I'll grant you that. So I mentioned four structures. I hope you can see them actually. The bone, skin, arteries. So if the three of the following, out of the four, if you have lost three of them, the three deficits in out of the four, you call it a mangled extremity. So excellent. So there's a score for it. It is called a MES, mangled extremity severity scoring. That is what roughly guides us whether or not we should be going for an amputation or should we salvage the limb. So this is the most commonly used score. The rough dictum is that if it is halfway around the score, like 7, more than 7, we usually tend to go for lean towards the amputation. But not always, not always, okay. So I am a plastic surgeon, so we tend to salvage most of the limbs. Okay, I truly understand that orthopedicians tend to take them off. But we are the other side of the road, we try to salvage them. Next slide. So I think you should know about this score. This is a Ganga Hospital score. It is in this hospital, renowned hospital in Coimbatore actually. So it's also called Mecca of plastic surgery in India. Surgeons in India come from usually Ganga actually. Dr. Rajshekharan, he and the fellow in the coordination with the plastic surgery department, they have revised the score. It's extensive. It's probably towards the soft tissue loss. It's difficult to remember. Next slide. Although management that is given by the Ganga Hospital is little difficult to practice in a mediocre hospital actually. They're a tertiary center. Probably they're better renowned and they're usually it requires a lot of manpower and a lot of infrastructure. So if we can just follow the my score, we should be doing good. Okay. Next slide. So this is our first case. I hope you can see that. Can you see the picture? I'm not sure. Okay. So how many of you think amputation is a better thing for this patient after looking at the picture? There are no wrong answers. How many of you think amputation would be a better one for this limb? Nobody thinks amputation is a better one. Great. I was called from my emergency telling that there's a bad case. Probably we should have to do an amputation. You should have a look. I said like, okay, I'll come and see. This is what the patient presented with. Middle-aged man, road traffic accident. He said security guard in Dreams Hospital. Accident while traveling with his daughter. He lost his daughter's life in the same accident. He was admitted with us. Next slide. So the MES score came around 5. This was the X-ray. There were multiple metacarpal fractures. There's a fracture in the head of the styloid of the radius. So we took the case up. Next slide. So the orthopedic team have given the fixation. They fixed all the metacarpals. They fixed the radius fracture. Change it. Okay, this is before the debridement. We have given it a thorough wash. We have used betadine saline for about 2 liters. After giving the wash, this is what the limb look like. This is post fixation after the fasciotomy of the hand. Okay, next slide. So this is after the debridement. I should say the patient got lucky because there was no nerve injury. Both the posterior interosseous nerve as well as the superficial radial, both were saved. But the bone was exposed, the elbow joint got exposed. I can literally see the synovial fluid coming out of the defect from the elbow. So next slide. So we planned to cover with the latissimus pedicle, latissimus dorsi flap. That is the flap you're seeing. That is the muscle. I'm not sure if you're able to appreciate it. So that is the second picture. Is what shows the transfer of the flap. Pointer, anything? Pointer, please. Pointer. This one. So this is the flap we harvested. This is the skin paddle. This is the latissimus dorsi muscle. And this is after we have transferred the flap onto the defect. We plan to cover the defect on the elbow with flap because the joint got exposed. The rest everything we try to plant a skin graft. Next slide. This is the on-table picture. This is the skin graft we gave. This is the pedicle. This is the latissimus dorsi flap. We covered it. This is on-table picture actually at the end of the operation after the fixation in the face shot. Next slide. So as the luck would have it, I will also tell you the mistake I did. I've taken the flap through the zone of trauma. Before. Yes. Go. I've taken the pedicle through the zone of trauma. So I had a bad experience here. So the pedicle partly gone. It's gone. Not the pedicle. The muscle was there. The skin pedal got congested on day 3. That's because the edema will be most on the day 3. That is where the skin pedal got congested. So we took him up for OT on day 3. Next slide. I've debrided the skin flap and put a graft on the muscle. Okay, that's taken up. Next picture. So this is how the patient was after like 2 weeks. He's still undergoing rehabilitation. At the end of the day, we could save his limb. We're hopeful that he'll do well. Next question. So this is another case. It's a crush injury, young male. He was traveling on his motorbike. He fell and the motorbike's handle fell on his hand, causing a metacarpal fracture of the 4th digit. And of course, when he presented to us, the CRT was delayed. The digit is looking blue. Okay, next slide. So these are the preoperative pictures. You can see there's a huge defect on the dorsum. This is the finger that is lying just connected by a skin bridge. This is the X-ray. The X-ray is not doing the justice because there's a fracture here. There's a fracture here also. So the whole of the metacarpophalangeal joint is just coming out like a segment out. It's barely attached by the interosseous muscles there. Next slide. So here comes the second question. Can somebody of you tell me what is revascularization and what is reimplantation? Can somebody of you tell me what is the difference between a revasc and a reimplant? There are no wrong answers. Next slide. ಮುಂದೆ better. So if ಮುಂದೆ better, go. So since the digit is attached by the skin paddle, this cannot be a reimplant. This will be revasc. Even if it is attached by a string of tissue, it has to be revascularization. It is completely amputated, then it is reimplantation. Okay, there's a difference. You should know that. Next slide. Next slide, yeah. So we have repaired the distal artery. One distal artery we could salvage. So I have repaired the distal artery and anastomosis. We have done 2 distal veins. I'm sorry about the pictures. The lighting is not good. These are the clamps. This is the anastomosis of the veins. So by and large, if you want to or reimplant a digit, you'll have to do at least an distal artery, either radial or ulnar. You'll have to do 2 distal dorsal veins. 1 artery, 2 veins. Because it is the vein that gives you the trouble in the post-operative period. So you'll have to have a backup, at least 2 veins, 1 artery should. Mostly it will do. Next slide. So this is the post-operative picture and this is the dorsum. The patient is doing well, he is also undergoing rehabilitation. We're waiting for the bone union. We'll take the wire up, we'll take the wire out. We're hopeful that he'll do well. Okay, next. This is another case, an adult female patient, road traffic accident. They were taken to somewhere hospital in the periphery of Vizag, and I got a call in the afternoon telling her somebody wants to come, showing this picture, but she doesn't have distal pulses. This was the X-ray, the completely shattered lower end of the femur. There are fractures in the tibia as well as the fibula. The pulses were not there, so we took her up. She reached to us in 3 hours, did a CT angio. There was a filling defect around the popliteal artery. But I thought, well, the imaging suggests it might not be a severing. It's just a kinking of the arteries because of the fracture. That turned true after, next picture. They have put in an X-fix, like the ankle spanning as well as the knee spanning. The bone defect they covered with the bone cement temporarily. They put in a spacer. For the exposed knee joint, we have given just a pedicled gastrocnemius flap. This is more of the orthopedic case more than mine. I've just given a tissue cover, but they did the hard miles, they did the hard work. They put in a big X-fix, they put in a spacer. I've just operated. My time, I took it in probably 45 minutes. We covered everything with the graft, but they did the hard miles. It was more of their work than mine. Okay, next picture. These are the intraoperative pictures. This is the primary closure. This is the gastrocnemius flap we took. This is the skin graft over the gastrocnemius flap. Next picture. So this is around post-operative day 14. She recovered well. The wounds got healed without any major issues. We're waiting for her to just pass the initial period. So we're planning to actually reconstruct the lower end of the femur with a vascularized bone. Most likely fibula double barrel. We'll do it in the long run when she recovers of the initial trauma. But as of now, she is discharged, she is at home, she is coming for follow-up. She doesn't have any infection, any sorts as of now, sir. Third, next one. So this is a case of a young male. He is an electrician by occupation. He was cleaning his motorbike chain early in the morning, and some of the mishap happened, and because of the bike chain injury, the completely transected index finger at the level of metacarpal phalanx. Okay, they came to us in half an hour. So we decided, I explained them there are chances, what are the chances that we will revascularize or reimplant. They were ready for the odds. So we took the case up. Next case. So I'm sorry about the picture. Actually, this is after the bone fixation and after the arterial repair. So like I've told you earlier, we'll have to do at least 1 artery and at least 2 veins. But I have a question for you. So can you please tell me the order in which you will repair tissues, be it revascularization or reimplantation? Can you please tell me the order in which the tissues are repaired? Like the muscle comes first, or the artery comes first, or the tendon comes first? Can somebody of you tell me? Yeah, you're right, bone. Okay, so you'll have to fix the bone either ways, be it a major reimplant or a simple digital reimplant. You'll have to fix the bone first. So everything else comes after it. Because whatever the repair we do, will go for a 6 if you don't fix the bone. Because I'll do the artery first, then you'll start fixing your bone, then everything goes for a 6. Okay, be it revas or a reimplant, you will have to fix the bone first. Next slide. Okay, better. Back. Bye. Next slide. Next slide. That side. Ah, that side. As luck would have it, I thought I have explored the amputated part, explored the proximal stump. I've got two nice arteries. I thought I'll do it as easily get away with the artery. But as luck would have it, I got the ulnar sided distal artery well and the radial sided in the proximal stump and ulnar sided in the distal stump. I think I'm communicating. So the arteries that were good and which can be anastomosed are on on the proximal stump on the radial side, on the distal stump they were on the ulnar side. So I had to put in a arterial graft. I've taken the arterial graft from the ulnar side of the digit. I've put it across from the radial side to the ulnar side of the digit. Actually, the picture was showing, but it's not clear here. Okay. After that, I've done two veins. Okay. Next. This is the on-table picture. You can see the nail bed is red. People say there are a lot of ways to relieve congestion. One is removing, so it will not cause congestion. People use leeches also, medicated leeches. That also work. I do not have an experience, but that are described in the textbook. Okay. Next. Mundu better. Before, yeah. But unfortunately, on the day 4, it went on well for 3 days. On the 4th day, the morning of the 4th day, it's on completely gone blue. Okay, this can happen. What I want to tell you is, out of 10 replantations we do, 50% of them will go for a 6. Okay, not everything will survive. You should tell the patient that the chances of survival are less than 50%. Out of 10 I did, I have lost 5, at least 5. I must have done few more, but 50% will you lose it on day 3. I have seen them losing on 21 days also. Okay. Next. So this is another case of lower limb severe crush injury. The auto toppled. The patient was traveling in an auto rickshaw and it toppled. Okay. The completely gone, but everything is open. He went to a local hospital. They have put in tagging sutures and sent it to us. Next picture. The metatarsal bones, the tarsal bones were exposed. The metatarsal, these were exposed. The rays were all exposed. The tendons were cut. Even there is vascular deficit in the foot, but the posterior artery is intact. Okay, the CRT is still maintained, not blue, but is still maintained. As you can see, all of them have gone for 6. The only thing that led us to salvage, of thinking of salvaging the foot, is the calcaneum. I spoke to my orthopedic team. They were like, "Sir, what would be your plan?" I said, "Like, sir, I think we can give him a weight-bearing foot rather than a functional foot." So we explained it to the patient. If he is ready for it, we'll go for a salvage. If not, we'll have to amputate. So he's ready for it. So we thought at least we can give a weight-bearing foot. I am really sorry, I do not have the post-fixation picture. Next. This is after the debridement as well as the fixation. I'm not sure whether or not you can appreciate the K wiring. They put in a big wire just to fuse the ankle. They have done the arthrodesis. They fixed the bones. This is the post-debridement picture. Yeah, there's a huge 20 into 12 centimeter defect on the medial side of the foot. Okay, this is post-debridement. I have debrided all the non-debrided tissue. I've hitched the positibial tendon to the tarsal bone just to maintain its function. Next. So we have harvested a huge anterolateral thigh flap along with the muzzle. This is the flap. This is the muzzle you see. You can see the color difference. This is a vastus muzzle as well as the skin paddle. This is the on-table picture. We started this case at 6 in the evening. Our orthopedic team gave the case to me at 9 in the night. So we started the flap at 9. We finished at 3 in the morning. 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 Next page. So this is how the anastomosis was done. We did the venous anastomosis with the great saphenous vein and the arterial anastomosis with the anti-tibial artery. I told you the postal tibial artery is intact, but the anterior tibial artery was proximally. We did, with the great saphenous, we did end to side. Next page. This is intraoperative picture immediately post-op. This is the skin graft we did. Because of the weight of the flap, it is just falling like that. Okay, so we had to take at least 4 centimeters of graft. We put in a graft, but we can adjust a drain. Next picture. This is post-operative day 7. The flap survived, the graft survived. We've taken the drain out. There was little duskiness, but we didn't have to debride it also. It was granulating, so we decided against any further coverage. So as of now, I'm here for the last 45 days odd. So we have operated 14 such cases of trauma. All of the cases we operated in 48 hours actually. Okay. So in my institute we used to follow the Godiva's principles. The coverage in less than 3 days, or you do it after 3 weeks. Because the intermittent period you have the highest amount of inflammation. So the chances of your flap or the vascular coverage, the soft tissue coverage going for a 6 are higher in the second week. So we do it either less than 72 hours, which is 3 days, or after 3 weeks. If you're doing after 3 weeks, the chances of infection are far more higher. If you do it under 3 days, the infection is almost like less than 10%. Next. Okay, so why choose us? So our GEMS hospital has an entire team, sir. Actually, we have a vascular team, we have a critical care team, we have a complete orthopedic team, we have dedicated plastic surgery OT, and the anesthesia team is always available. So all of the cases I've showed you, we have operated in the middle of the night or early in the mornings, and we have all of them we have operated in less than 48 hours. I would not have done all these things without the cooperation of my orthopedic colleagues. So next. So I thank you for your patient listening.
Any questions, any queries?
Yes.
So if we open injuries not apart, so it's multiple present injuries.
Yeah.
So if reconstruction is good, functional outcome is okay, sir.
Next. This particular person, I thought of putting it, but I don't be very long. So he smashed his hand against his glass. He fought with his wife. He smashed his wrist against. There were cuts here, 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 and here. So I opened. I'm not sure if you're able to appreciate. There's multiple tendons cut. This is the flexor radialis, FCU, the median nerve, and as well as the flexor tendons. So I've repaired them all here, but there's a stab, another stab here. So I've just opened and I've just started to explore if there is anything more cut. So to my surprise, and if not for it's a learning for me also, the median nerve was cut here also. So it was a segmental cut. It was cut here. The tendons were cut at 2 levels. Even if you see, even after repair, the cascade has not come. Usually, if it is a single side repair, usually a hand comes in a cascade after the repair. So even after my repairing the one place, the cascade has not come. That is the reason why I explored a different place. So coming to the question, if there are multiple tendon injuries, only tendon injuries, the outcome is, it should be very good, provided good repair in the sense if you have taken 4 core sutures, at least 4 standard repair, as well as the epitendinous repair. Okay. Secondly, you will have to take immense care about your post-op rehabilitation. So what I do on 3rd, 4th day, I'll start passive range of mobilization. I'll go on to active range around 2nd week, depending on the patient's compliance. For 6 weeks, I'll keep them in a splint. Initial 14 days until I remove the sutures, I keep them in the POP slab. After that, I'll shift them to a the light weighted thermoplastic split. Okay. There are a lot of reasons why your tendon repair doesn't work. Okay, one is adhesions. It will stick to the bed, it will stick also to the skin. One. Secondly, poor rehabilitation. Third is smooth patient compliance. The patient will not move because he'll have a lot of pain. Okay. So pain control is very, very important, because unless the pain is, you have not taken control of the pain, you will not move the digits. You will not move the digits, 4 weeks can't help. You'll have to go in again to do the additional assist. Post-op immobilization, physiotherapy, positioning. 3 important things in a tendon repair. If it is not nerve repair also.
Thank you, sir.
Thank you.
Thank you, you and James Hospital.
Oh, no, sir, not yet.
Connecting this such a wonderful facility. I am Dr. Sanjay, sir. And Srikakulam people are lucky because you are here. Your services are available. Because previously there is no such cases are doing here in Srikakulam to this day. So all cases are referred to by sir. So now we are happy with watching of your cases and everything. So we get some confidence. We definitely can do some more cases instead of. Thank you, sir. And I have some questions.
Please, sir, please.
Uh, that implantation.
Yes.
So that is for. So at that implanted part, I mean, temporary part.
Yes.
Morning.
Yes.
How they bring to.
Yes, sir. Yes.
And
Yeah.
what are the protocol, how to take that?
Bring it. Yes. I think it's my fault. So I should have put in a slide, but we'll circulate that e-poster, sir. I have a poster. I've already given it to my PGs and the postgraduates in orthopedic as well. So ideally, if something like that happens, you'll have to keep it in a gauze. Okay. Once gauze, keep it in a polythene bag, then keep it in the ice. Okay. So don't keep it directly in the eyes, because it just macerates it. Okay. With this patient, that was not a problem, because they have reached the hospital in 45 minutes to 1 hour. They stay nearby, so they came like that. So it was not a problem. But if the patient is coming from a faraway place, then all these things should be done. I'll circulate the posters. I'll have it sent it to you. Surely.
And how do you decide that the part, family party
Yes,
can
yes.
implant or not?
Yes. The first thing, I'll explain to the patient that what are the chances of this being a successful one. The counseling is very important. As I told you, out of 20 odd things I did, 10 must have answered. Okay. Various different reasons. Instead of doing a good surgery, they can go for a 6 on 21st day also, like I told you. You will have to tell the patient that there is a chance of losing it even after a good operation and he is being discharged. That is first thing. If he agrees to it, then we take up for the surgery. We'll consider the NPO. Most of them are done in the block, so NPO is also not an issue. But for the bloods to come, I'll ask the patient and ask the PSC team to have their workup. I'll take the part after taking the consent to the OT. So I'll start dissecting on the table even before the patient was shifted to the OT. So that's what I did. So for me to decide whether or not I'll be starting a reimplant, I would have dissected and seen there is at least a good stump on the at least one artery. The veins will open up after you've done the artery. Because there's blood coming in, the veins will show up after you've done the artery. Okay, sir. But sometimes that is not the case. This is almost a clean cut. Bike cut is very common. Sometimes what happens is they'll be coming with a finger avulsion. So in that case, we can't give any guarantees. And most of our losses in cases like that, because the arterial injury is various different levels. Okay. You might be seeing the injury here, the artery is injured somewhere else. You can't help it, sir. You can't help it. So the chances of reimplantation in those digits is even more lesser. Okay. So I do the table dissection first. Once I'm happy that I will be able to anastomose, then only I'll take the patient in. It happens in 1 hour probably around. So by the time the patient is seen by the anesthesia team, he gets ready and gets over everything. So then I'll tell the patient that there is a possibility, but whatever, the risk still stands. Yes.
Thank you.
Thank you for the kind words, sir. I'm not a big man. There are people better than me. I hope to continue the work.
speaker, Dr.
Bully sir.
Now, the plastic surgeons have a great role in today's daily life of fractures, hernia injuries, along with the orthopedic surgeons. So I expect you have better work in plastic surgery department in the Children's Hospital. I thank the Children's Hospital for having sponsored this very useful topic for the postgraduates and orthopedic surgeons. Thank you.
Thank you.
Thank you very much, sir.
Thanks. Thank you.
For your excellent presentation on limb salvage for trauma cases. Especially the reimplantation case was because we government orthopedic surgeons used to get many more number of these sort of cases, especially in the casualty, because many number of cases are medical legal cases, so they directly deal with the government hospital. Suppose any such trauma case,
Please, sir.
so
We'll be happy to have,
we cannot manage such cases.
Sure, sure, sure.
Once again, thank you very much for your nice presentation.
Thanks.
Thank you. They are all hospital services for coming and everything is very problem.
Sir, sir, all of these cases are included in ROVC, sir, by the way. Yeah, reimplantation is there, revascularization is there. All the cases were in ROVC, by the way. Yes. Thank you so much, sir. Thank you for coming.
పోస్ట్ ట్రామాటిక్ కేసెస్
Sir.
నీ జాయింట్ ఉంటాయి కదా
We covered, no
బాటల్
problem.
అండ్ స్టిఫ్నెస్ ఉంటుంది ఈ క్వాడ్రిసెప్స్ ప్లాస్టిక్లో మీకు ఏమైనా ఎక్స్పోజర్ ఉంది
So stiffness,
అంటే
stiffness secondary to
నాన్
okay,
యూనియన్
sir.
బటల్ ఆఫ్ నాన్ యూనియన్
Okay,
స్టిఫ్నెస్
okay, okay.
30 degree ఫ్లెక్షన్ వస్తుంది అట్లీస్ట్
Okay.
90 degree ఫ్లెక్షన్ వాడికి కావాలి ఈ క్వాడ్రిసెప్స్ ప్లాస్టిక్లో ఏమైనా మీకు ఏమైనా ఎక్స్పీరియన్స్ ఉందా?
I mean, sir, because of the quadriceps tightening, you're saying
ఎస్
we can release the tendon, sir, not an issue. In tendon
Will
lengthening,
you get the range of movement at least to 90 degrees?
sir, I've done Achilles lengthening, sir, not the quadriceps, not the quadriceps, because I never came across
Regularly we are
anything.
getting more number of
We'll
that,
start, sir, no problem. No problem. I'll see. I'll just check with my colleagues, sir, but
many
if we
number
do,
of knee joint injuries especially, either distal femur or patella fractures. They are having
so you're
restriction
saying
of
it's all
movement.
because of the quadriceps?
Yes, purely due to quadriceps.
Okay. I'll find out, sir. I'll get back to you.
Plasty and all that.
We'll do, sir, not a problem, sir. All the